Like Dr. Moeller said, I'm in the MD PhD program, and I'm pursuing a dual degree because I'm fascinated by both the research and the patient care sides of medicine. It's a long 8-year program, but I fell in love with cardiology research 5 years ago when I joined the lab of Dr. Fedorov, and I saw a human heart beating outside the chest for the first time. To study human disease, the best way to do it is to study the human heart directly. There's some information that can be gained from an animal model or a single cell study, but the pinnacle of disease research is to study the human heart itself, because that's what we really want to fix. At OSU, we have the unique opportunity to get human hearts from transplants and from donors whose heart isn't fit for research, or heart isn't fit for transplanting to a new patient. And so we get it for research instead. Or when someone gets a transplant at OSU and gets a new heart, we'll get their old heart and can study the heart failure. We then get the hearts from these transplants, and we're on call 24/7. Just like the surgeons and the patients, I go to the OR in the middle of the night, the surgeon will turn around and hand me the heart, and then I have to act very quickly, and in the OR, we flush the arteries from all the blood so it doesn't clot, and we chill it on ice. Just like a doctor would be keeping for a new patient, we do the same exact things, because just like the doctors, our goal is to keep the heart alive. At OSU, we then bring the hearts back to our lab. Here's a diagram of a human heart, and at OSU, we have about 20 different labs that each get a little part of the heart. In the Fedorov lab, we get the atria, or the top 2 chambers above the dotted line. We're very interested in the atria because there's a special group of cells in the atria called the Sinoatrial node. Here is human atria as it would be set up in our lab, and this red oval marks where the sinoatrial node is. These cells are so special because they generate the electrical signal that tells the rest of the heart to contract. It's a little known fact that the brain only tells the heart to go faster or slower. Everything the heart needs to contract is in the heart itself. When we then bring the heart back to our lab and we hook it up to our system and we pump a blood-like solution through it and warm it up to body temperature, the heart will start beating again on its own. This video is of a heart beating. Again, we're not pumping this heart at all. This heart is moving on its own at a normal rate of about 60 beats per minute. And this is very normal, but if the patient had an arrhythmia or an irregular heartbeat, that would have manifested itself outside the body also, and we would have been able to study that. We studied these irregular heartbeats by looking at the electrical signal of the heart. We do this with a very unique technique called optical mapping. Here's a picture of me setting up the optical mapping system. It looks very complicated, but it can be broken down into a set of lights and cameras. The lights illuminate a special dye that will change colors when the electrical signal activates the cells. And then the cameras pick up this very subtle color change, and we're able to create movies of the electrical signal as it moves inside the heart muscle. I'm going to play one of those movies for you now. You won't be able to see the heart directly in this blue field, but just imagine that the camera is focused on the atria to the right or to the left. Blue is inactive cell, and that red is that electrical signal that we're watching. This would be a very normal heart rate. It's starting in the sinoatrial node, that special group of cells, and then spreading to the right and left atrium. But again, if the patient had an abnormal heart rate, we'd be able to see why and where in the heart the problem is, and we can glean a little bit more information on how to fix it. We also do this by marrying the function of the heart to the structure of the heart. And we study the structure of the heart with a technique called cardiac MRI. With cardiac MRI, we're able to create a 3-dimensional structure of the heart muscle. And with this information, we're able to see where in the heart an electrical problem is, and then see, is this electrical problem based on the structure itself? In the Fedorov lab, we study specifically 2 different arrhythmias. One where the heart is beating too slowly, called Sinoatrial Node Dysfunction, and one when the heart is beating too quickly, called atrial fibrillation. The first arrhythmia that I'll talk about is Sinoatrial Node Dysfunction. This is when the heart beats too slowly, or when the heart pauses or even has a rest. Although the saying, "you make my heart skip a beat," is endearing, no one wants their heart to pause. Currently, the only treatment for sinoatrial node dysfunction is an electronic implanted pacemaker. And this pacemaker works like a metronome, always at the same rate. But we know that if we're climbing stairs, we want our heart to beat faster. Or if we're falling asleep, we want our heart to beat slower. Unfortunately, pacemaker patients don't have this luxury. And so we have to ask ourselves that there must be a better way. But to figure out a better way, we first had to understand the human sinoatrial node a little bit better. In the Fedorov lab, we looked closer at the human sinoatrial node, and by using our integrated functional and structural mapping, we were able to create a 3D model, so shown on the left, of the real human sinoatrial node. And we discovered that it's created by both intranodal pacemakers, shown in the blue region, that act as batteries that generate the electrical signal, as well as wires or conduction pathways, shown in yellow, that connect the signal from the sinoatrial node to the atria. And with this information, we're now working with clinicians at Ohio State to diagnose patients' sinoatrial node dysfunction as either a problem with the wires or the batteries. And the next step would then to tailor treatment to the patient's needs. Do we need to replace a battery or repair a wire? This could revolutionize the treatment of sinoatrial node dysfunction. The next arrhythmia that we're looking at is atrial fibrillation. And like Dr. Moeller pointed out, it's a very prevalent arrhythmia, as most of you raised your hands. This graph shows that the prevalence increases with age. And people with over 85 years old have about 10% chance of getting this arrhythmia. This arrhythmia is so dangerous because it's the leading cause of stroke. Instead of beating in unison, as it should, the atria just kind of quivers. And this is caused by an electrical storm or chaotic electrical activity in the atria, which prevents it from having a very smooth contraction. But instead of just seeing chaos, at Ohio State, we're trying to look through this disorder and see if there's any organizing centers somewhere in the atria that's then driving the rest of the arrhythmia. Recently, we showed that in our explanted hearts that these drivers could look like circuits or tracks, little circles that the electrical signal is moving around in a sustained pattern. And these drivers are targets for a procedure called ablation. Ablation is when a catheter is introduced through the vein of the leg, and a small part of the heart is burnt. If you cut these circuits, you may be able to prevent the electrical signal from spinning in this area, and you could treat the arrhythmia. This sounds simple enough, but these drivers, these circuits, are very difficult to find within the chaos of atrial fibrillation. And so now we're working with clinicians at Ohio State to improve their techniques of finding and ablating these drivers. Currently, the best way to find these drivers is with a device called a basket catheter. Basket catheters, again, are introduced through the vein of the leg, and then they open up inside the heart and can record signals from 64 points within the chamber. They create movies like this one, where white is activation and black is inactivation. And again, we're looking for a sustained circular pattern in the white. I'm going to play this movie for you now. With only 64 points, it may be very difficult to see any order within this chaos. And even myself, with a very trained eye, would find it difficult to find the driver in this. But this is what clinicians have right now to target these drivers. Since we use human hearts outside the chest, and we have our high-resolution optical mapping system, instead of having 64 points like the basket catheter, our optical mapping system has 40,000 points. And with this technique, we have a much easier idea of where these drivers are, and then we can use this in combination with the clinical device because we're doing this in a human heart. And then we can move forward to try to improve the clinical device. This is now an optical mapping movie of the exact same arrhythmia. And hopefully many of you can tell me where the driver is in this movie. Again, a very sustained circular pattern. If a clinician can find this, they can target this, and they can cure the arrhythmia. We're also looking to see, do these drivers have a structural pattern? This is the exact same heart seen by MRI. And we can see that there's a very unique set of muscular bundles, shown in color, that created the circular track that the arrhythmia moved around. And now we're working with clinicians at Ohio State to start a small clinical trial. In this clinical trial, patients who are going in for an ablation will have an MRI of their heart first to see if the combination of MRI and the basket catheter can significantly improve the success of these arrhythmia treatments. I'm very humbled to be at the cutting edge of research at Ohio State, to be studying the sinoatrial node dysfunction and atrial fibrillation. And I hope that one day, the techniques and the information that we gain here in my research, I can use to help treat my future patients. Thank you.